about all hospital systems being very much over capacity with very high census numbers, particularly because of an inability to discharge patients into post-acute care settings, so skilled nursing facilities or long-term care beds. This morning and earlier today, Harborview reached an unprecedented census level. We are now at over 560 patients in a hospital that is set up for 413 patients. We have over 150 patients more than our licensed beds. 100 of those patients are medically stable individuals who are in need of moving out of a hospital, any hospital, not just Harborview, and moving into a long-term care or post-acute care setting. Given the unique position Harborview has in the community as the Level 1 Trauma Center, as the disaster center, and here for all critical illness, we've had to make a very difficult decision today, one that has been weighing on our minds and one that we have struggled with as UW Medicine leadership and as the Harborview CEO for many months. In order to ensure that we maintain our critical capacity for any type of trauma that is needed in our region and for any type of critical illness, we have moved to going on what we call basic life support divert, which means patients that are not in need of more urgent care will be needed to be taken care of and brought by ambulances to other hospitals surrounding Harborview in the area. Harborview will no longer, for this time period, be able to take care of the less acute patients in order to maintain our capacity. This is an incredibly difficult decision. As you can imagine, our staff and our providers and our leadership at UW Medicine and at Harborview are incredibly dedicated to the mission and the role that we provide. But we've reached a level at this point where we do not feel it is appropriate or safe to take in any more patients that don't require the unique, very skilled expertise of the providers and staff that we have in-house. We are going to work very hard with our hospital partner systems. I met with other CEOs of different hospitals this morning who were incredibly collaborative and incredibly generous. They are aware of what Harborview is doing right now and are ensuring that they are set up and ready to accept patients in lieu of them coming to Harborview. I want to thank them for their partnership and their collaboration. We have also worked incredibly closely with both the state and the county to ensure they are aware of our situation and are working very closely with us to mitigate the situation. I'm going to pause there and let Steve have a comment.
Hi, good afternoon. Again, my name is Steve Mitchell. I am coming to you as the acting medical director of Harborview, and I am also the medical director of the emergency department here at Harborview as well. And so, as Summer said, we have been challenged for weeks and months. You've heard hospitals talk about that, and yet Harborview has been significantly impacted, and we remain significantly impacted with now with 150 more patients than we have licensed beds to take care of them. And importantly, as she said, 100 of those are stable and ready for post-acute care beds. And so what this BLS, or basic life support diversion, means is that we are now seeing impacts across the entire healthcare continuum, which we've spoken about before. And so the continuum starts, as you know, when people dial 911 or come to emergency departments. And so what has been happening is that when ambulances arrive in emergency departments, they're unable to offload their patients to beds inside the emergency department, and they're having to wait for longer and longer periods of time, sometimes even hours, before they're able to offload their patients, which is then impacting their ability to serve the community for their emergencies when they occur. And we also want to emphasize that we are going to extraordinary lengths to make sure that every patient who is at Harborview is being cared for in a safe and effective manner, but yet that that challenge around safety has been what has led to our decision, regrettably, to temporarily go on basic life support divert. But as Summer also said, we are working very closely with not only UW Medicine partners, but also the other hospitals in our region, as well as leaders in the state, to address this crisis, which is both long-standing, but also has acutely gotten worse to where we feel like we needed to make this decision in order to keep providing safe and very effective care with high standards that we have. We'll be happy to answer questions.
You guys want to ask? Does anybody need to move closer to the mic?
Just whoever talks.
When you talk, get as close to the mic.
Sure.
Could you give a couple of examples of what non-urgent exactly means? And could you give a couple examples of what a non-urgent situation would be? And are there any situations in which the time spent waiting to get in which something could go from non-urgent to urgent?
Sure. So, just repeating the question, what's an example of a non-urgent or a basic life support scenario that is being impacted? So, when people dial 911 and an ambulance comes, those EMTs and those paramedics are very highly trained to be able to sort through who's having a life-threatening or a very serious critical illness occurring, and we remain open and very, very committed to those patients, or patients who have a less urgent or less acute problem that can be safely managed without critical resources, and the illnesses that are not that aren't quite as time dependent as those critical care incidents. And so it could mean something like I'm having an appendicitis, or I'm having abdominal pain, or my breathing isn't quite right, but it doesn't reach the threshold of really being considered to be life-threatening.
Did you ever think, it just seems like the past 2 years, 2.5 years has really tested your limits. Did you think there was going to be more and more challenges, post-pandemic? I mean, we're still in the pandemic, but did you think this challenge was ever going to come?
If you would have asked me that maybe at the beginning of the pandemic, I would have said that was the most challenging time. This is definitely the most challenging time of the pandemic. And about 6 months ago, I could have guessed this, because we have not been able to make movement on the ability to utilize post-acute care resources. So that is why Harborview has been so actively in UW Medicine working on ways to expand our footprint and ensure we can take care of patients very safely, but in an expanded manner. One thing I want to reiterate from the last question that Dr. Mitchell answered is that because Harborview is that trauma setting, and because we are so good at traumas, we are very good at being very quick to bring in patients off ambulance bays, triaging them quickly and in through the ED into the hospital. That's a unique skill. And so that often brings more volume to Harborview, because we are very good at being very quick at that. And so that also can add to the fact that Harborview is in a very unique position where our census is much higher, and why we need to kind of say we need to pause for a minute on those less life-threatening patients that can then also be served in other facilities.
What are some examples of the other hospital facilities where they may potentially need to consider?
Oh, yeah. So typically hospitals, the basic life support circles around hospitals that are close together. So our partners, including Swedish First Hill and Cherry Hill, Virginia Mason, those would be great examples of hospitals that we've been partnering with that will need to take a few more patients because they're in close proximity.
Do they have the capacity to take them in?
I did meet with them this morning. They do have the capacity to surge a little bit and take patients. No hospital is in a position like they were before the pandemic where they have space, but everybody is working together as a system to find more space. These hospitals are not, Harborview is not unique in that they also have patients who need to move to post-acute care settings. It's just that Harborview, because of our unique role and the complexity of who we serve and who's part of our mission, oftentimes those are the most challenging and difficult patients to place into post-acute care settings, so our numbers are higher.
It seemed like months ago, hospitals were approaching the governor's office saying this is going to be a huge problem, we need your help, we need it fast. else can they do? What can they do right now, and how quickly can those things happen?
Great question. So we have had very good partnership from the state, the governor's office, Healthcare Authority, and DSHS, along with the county. About a week and a half ago, we had a very large group of individuals from the state come out to see firsthand what is happening at Harborview and the ways that we've surged and how we're having to find ways to take care of patients that no longer need to be in these facilities. They are very aware, acutely aware of the problem, and are partnering with us not only on some temporary solutions on how to focus staffing resources that they may be able to help with into facilities that can take Harborview complex patients, but also looking at more long-term sustainable actions that would occur during the legislative session to work on this.
You talked about the difficult to discharge patients as being part of what's making these capacity issues so tough. But are there any other factors that are specific to Harborview that's also contributing?
Yeah, I think, and this isn't specific to Harborview, I think the delay in care, and I'm going to let Dr. Mitchell kind of talk about what the pandemic did when people weren't seeking health care and how that has led to an increased need for health care now. Harborview is always busy during the summer, right? People get injured more when the weather is nice. So that is a little bit unique to Harborview. But I'll let Dr. Mitchell talk a little bit more about the pent-up demand for health care that's happening right now.
So, since the pandemic and since so much care has been deferred, we are seeing that, and importantly, that has to be combined with the reality that the population in Seattle and King County and the region is growing, and our population is also aging as well. And so what we are finding is that the patients who are arriving in all of our hospitals, not just Harborview, are higher acuity, are just sicker than they once were. An example of that would be that things like hemodialysis, the need for hemodialysis has gone up somewhere between 30 and 50%, not only at our hospital, but also the other area hospitals. Some of that is because some of that is because the staffing challenges that are everywhere in healthcare right now. Every day there are patients who reside in our area hospitals that could be taken care of in dialysis centers that are in an outpatient center, but they are also having staffing challenges. So patients have to remain in the hospital longer because they in turn are having challenges. And so, but in general, it's because of staffing challenges in our system, which is making the entire system more challenged and inefficient, and because of the aging population, deferred care, and just overall rising population as well.
With that, when you talk about the staffing challenges and staffing issues, what is morale right now with staff here at Harborview? Because like you said, you guys are taking an influx of patients, and now you have to limit it.
Yeah.
I can imagine they're exhausted.
Yeah. I actually just got off a big town hall with leadership at Harborview, and you are absolutely right. Frontline staff, providers, leadership are exhausted. However, people that work at Harborview work here because they are so incredibly committed to this community, this region, and the mission that we serve. They are incredible individuals in those walls who have been working tirelessly to maintain the safety of the community and continue to be dedicated to do so, but they're tired. They're tired and they're frustrated, and they need a little reprieve. And I think that is not unique to Harborview, but what is unique to Harborview is the intensity of which this census has continued to barrage them. And one of the factors in making this decision this morning really is, at this number of patients, we cannot expect our providers and our staff to undergo that kind of pressure at the same time when you're trying to work in settings that aren't typical healthcare settings. You're surging into spaces that aren't typically meant for medical care.
And to what you were saying earlier about the system as a whole, it seems like, the last 2.5 years, the system has been through the ringer. Do you think what we've experienced the last 2.5 years, the system needs to change?
Yes. in brief, yes, and we are actively looking at that, but it's hard to kind of fly and build the plane at the same time, and so we are constantly. Since the pandemic began, we have been at unprecedented levels, and we are tired of, frankly, the word unprecedented, and to where we are both locally at Harborview, but also in the region and in conversations at the state and, frankly, the federal level, looking at all the ways that healthcare needs to change operationally to make sure that that entire continuum that starts when you dial 911 and goes all the way through to what we refer to as post-acute care is healthy and functioning and is able to meet the demands of the community, because right now our resilience is probably at an all-time low, if we're honest, and we are coming at this at a time when we are seeing more and more stress in the healthcare system, more and more disasters, whether it be natural disasters or people-generated disasters. And so we're concerned about that, and we are looking under every nook and cranny and every rock in order to figure that out.
At the same time, your workforce is also partially these maybe not out of city, but these are travel contracts that are much more expensive. At a time where hospitals have been trying to get away from that practice, you need them now more than ever, given the surplus of patients. How sustainable is that from a hospital standpoint? How much longer can hospitals go paying these exorbitant wages?
Yeah, I would answer that first by saying you're absolutely right. Healthcare has had to rely on contract labor because of shortages for staffing. Large amounts of nurses and other healthcare providers have left the profession because of a lack of ability to feel like they can continue going. It's very, very incredibly stressful across the country. UW Medicine and Harborview is very committed to ensuring that we staff to a safe level every day. We have used an incredible amount of contract labor, which is very, very expensive. It is not sustainable. It's not sustainable financially because it starts to erode your reserves, right? You cannot pay that much and think that you're going to be able to maintain operations. However, it is also a blessing we have contract labor. They are very good individuals. It is also really complicated because they're not necessarily familiar with the facility or the teams. So it is harder to provide care because you don't have that inherent collaboration that you're used to when people are used to working in a facility together, partnering and teaming together.
When people are diverted to a different hospital, how long on average do they have to wait, and what happens if their condition deteriorates in that time?
You know what, do you want to explain, Dr. Mitchell, what divert means? It doesn't mean you come here first and then get diverted.
Sure.
Yeah.
Yeah, what we mean by basic life support divert is that when the medical professionals who first encounter a patient make the decision that it's not a highly acute situation, then they take the patient to an appropriate hospital that can meet those needs. And so, and all of the area hospitals that we talked about, both on Capitol Hill and the surrounding area, can do that, can certainly do that. And so we are in constant conversation with area hospitals to make sure they still have the capacity to meet those needs, to be able to staff their emergency departments in their hospitals to be able to meet those needs. And that's absolutely informing our decision locally as to what our status is. I'm sorry if there was another part of your question.
So they're not coming here first and then going somewhere else.
Correct.
I was picturing them coming here, waiting for hours.
Yeah.
No, we are still working with our partners in the emergency medical services community, the EMS community, to make sure the patients are still arriving at a hospital that can meet all of their needs. And only rarely would those patients then need to be later transferred to another facility.
What are some examples of post-acute care facilities?
Yeah. So post-acute care facilities is just a name that encompasses skilled nursing facilities. So where you think of when you think of, sometimes people call them rehab or skilled nursing facilities. It also includes things like adult family homes or beds within those facilities for patients that will be there for very long term. So any type of patient that needs continued care, but not at a level where you need medical care, but you may need help with medication, you may need help with dressing, showering, movement. Those are the types of individuals that are here that we aren't able to move in.
Can you explain why they're having so much more backup now as opposed to in the past?
Yeah. So this is not necessarily unique to the pandemic for Harborview. Harborview has always had this issue, and because we've had an ability to surge, we've been able to accommodate it for a very long time. Pre-pandemic, about 18% of our population in those walls were individuals who should be in the next level of care. As the pandemic hit, what we saw happen was, first of all, facilities had to close or reduce numbers because of COVID outbreaks in them. And then the staffing issues, the same staffing issues you hear that are hitting all parts, not just healthcare, but all industries, have definitely impacted our partners within the post-acute care region. So they aren't able to have enough staff to open up the beds. The last complexity I would point out is that where there is capacity, it is unlikely that a facility is going to first choose the most complicated individuals that reside at Harborview. So it's a scarce resource that then is harder for Harborview to access because our patients do require very strong wraparound services, right? We are a very complex medical center who handles very complex patient care. And those individuals are more in need of more staff and more resources than typical facilities can provide.
Is there any estimate right now about how long Harborview is going to have to divert some of this care?
Yeah, that's a really good question. We have let our hospital partners know on our earlier meeting today that at the minimum through the weekend. However, we constantly, every hour, are reassessing where we are. We're looking at not only just sheer numbers, but it really has to look at what's the complement of complexity within the hospital. How many ICU patients do we have? How many patients that need very intensive care? All of those things really impact our ability to function. So it will really depend on when we feel like we can safely take on patients that are not just trauma or critical illness. We are really doing this at this point to preserve our ability to be the level 1 trauma center and ensure that all trauma and critical illness have a place to go.
What does it look like in the hospital right now? How are you accommodating the 150 extra people?
Yeah. It looks impressively organized, I would say, but also very complex. If you walked in, you would see units that were very full. You would see patients in some hallways on units. You would see incredible work that our facilities and engineering departments have done, turning conference rooms and offices into patient care areas. You would see other spaces that have been not occupied but that are open, turned in by our facility and engineering departments into patient care areas. So you would see a lot of very incredible space that's been transformed.
How close are we to seeing the state have to step in, as we talked about in the early days of the pandemic, a field hospital to take in excess patients at any level? How close are we to that?
I think when that level happens, it would actually be the health systems in partnership with the state bringing up those types of facilities. I think what we would like to do first is capitalize really on whatever patients we can safely move into those post-acute care settings if we were able to provide more staff to them. So in partnership with the state, who are trying to find teams of individuals to send into these facilities, they then can take our patients. When that's exhausted and we find ourselves in this situation, that's more when you would see that. But that would be a very strong partnership between the state, the county, other hospitals, and Harborview as the disaster control center.
When was the last time Harborview has had to do this?
Yeah. So the last time we did it was actually, we looked it up, was
March in 2019.
March of 2019. The difference now, and the reason why this weighs so heavy on us as staff and leaders at Harborview, is that in the past, when Harborview had census problems because of this difficult to discharge, other hospitals had capacity. They had more capacity. So when we would go on divert back at that time, there wouldn't have been as much impact to others. And so the coordination, collaboration, and need to communicate to ensure that these patients still are going to be taken care of had to be thought through much more carefully this time around. We're just in a different place with the pandemic than we were before.
How big of a role is COVID playing right now?
I didn't hear that.
How
Sorry.
big of a role is COVID playing?
I would say not that big of a role, but I'm going to let Dr. Mitchell answer.
First, I need to amend. It was actually September of 2019.
Oh.
My partner just updated me that's why I was looking at my phone. COVID, in one sense, it's all COVID. It's all the trickle-down COVID impacts of the pandemic. But COVID specifically is having a smaller and smaller impact on all of our, direct impact on all of our operations. The number of patients with COVID in our hospitals has gone down. Statewide, we're at roughly 600 patients, whereas just a few weeks ago we were at 800 patients. And so statewide and in King County, that absolute number has gone down. And what's different about compared to now and other periods of the pandemic is that the primary reason why they're coming to us is not because of COVID. It's, I'm having a heart attack, I'm having a stroke, I was in a car crash, and we discover that they have COVID while they are being cared for. And so the direct impact is much less than it was at other points in the pandemic.
What does
It's like having to clear a car accident, and COVID set everything up, and there's just so much backup.
I'm sorry, one more time?
It's like clearing a car accident. COVID was the accident, and all the backup.
Yeah.
Yeah, no,
Yeah.
I think that's a good analogy where if the start of the pandemic was a car crash, and we are very familiar in Seattle with long traffic delays, and so there's a 10-mile backup that has been caused by the pandemic, and all of healthcare is working to clear that backup, and do it with more challenged resources and tired resources than we did originally.
How much does a decision like this delay that long-term recovery for a hospital like Harborview, trying to work through the backlog of delayed care and getting staffing levels back to a sustainable level?
It will be a long time before the healthcare system in the country right sizes itself, and Harborview included, right? It will take a very long time to recover from a staffing perspective, from a resiliency perspective, from an occupancy perspective, because we are going to continue to see this backlog of need for medical care. I also just think the area has changed, population has changed, and healthcare needs to transform with that, and that's what we're working on with our state and county partners.
You mentioned that.
Oh yeah. One of the blessings we have, and that came, during the pandemic, was the voter-approved King County bond that will allow Harborview to expand from a capital perspective into a new tower, which will provide us with single patient rooms, an ability to expand capacity, an all-new ED, more operating rooms and procedure rooms. That is incredibly impactful, and every day we thank our lucky stars that the King County voters were so supportive of Harborview, because that is so needed for the health of our public.
Is that on site here, that location?
Yeah, you're kind of in it.
I was thinking
You're kind of in it. Yeah, you're kind of in it.
all the grass.
Yeah.
Are there any other services that are at risk of being temporarily cut?
At Harborview?
Yeah, right.
No. Harborview and UW Medicine are incredibly committed to delivering our mission, healthcare to the population. So no, not here.
So with the expansion, you're talking about all that. It's got to cost money, but just when it comes to issues like this, does it make you reassess your funding, how you guys spend money when it comes to expansion of capacity and
Yeah.
services?
Yeah, it does. Harborview operates on its own operating revenue. However, capital expansion, so if we are going to build a new building, comes from King County voters. So that doesn't necessarily impact the bottom line operating budget. operating those buildings does.
So, but Governor Inslee in his term has given millions, like $300 and something million to statewide hospitals. Have you guys not seen any of that money, or are you guys on a different playing field? For my clarification.
I'm not sure I know which money you're referring to, so I'd probably defer that question.
Okay, just when it comes to funding in general, like I asked, does it make you rethink? But when you have to limit how many people can go in and out of your building,
Yeah.
do you guys think you need more funding to help out?
Oh yeah, healthcare in general needs more funding, but it also needs to be more better organized from a system perspective across the board. Harborview absolutely always could use more funding. It is we're a safety net, and all safety net hospitals across the country struggle with funding because we operate on very razor thin margins because we take all individuals, and our payer mix is much different than other hospitals.
Any last question before we wrap up? When you say census, is that the same thing as capacity?
No.
What does census mean?
Census means literally how many patients you have that are admitted to your hospital. Yep.
I know during the last legislative session, we were talking about trying to fix this nursing home issue, trying to cut some of the red tape with power of attorney and people not being able to send their relatives to hospital or to nursing homes. What would you like to see happen during the session that didn't get passed?
Oh, I don't think I could specifically state that there was something that I would have liked to see happen differently during that session. What I would like to see in the upcoming session is exactly what everyone's working on, reassessing policies around how post-acute care is funded and how it's sized.
Okay, I think we're going to wrap it up now. If you have one burning question, we can take it separately.
Thanks, everybody.
Thank you.
Thank you guys, really appreciate it.
Thanks.
Thanks for sticking my